Hey everybody, Dr. Jamal Rahimi here, and today I get the very, very cool chance to talk to one of my favorite people, another ER doctor, and really one of the unicorns in emergency medicine, because not only is he an ER doctor, he's also plays as an ICU doctor because he's fellowship trained in both and boarded in both ER and ICU, and he'll tell us a lot more about that in a little bit. But I am talking about none other than Dr. Michael Menowsky. Mike, welcome.
Hey, brother, what's going on, man? Honored to be here, and thank you for taking the time to talk with me.
Thanks for taking the time to come and talk today because I know there's going to be a lot of questions, and I definitely have a lot of questions because you are one of those, and I call you guys unicorns. I mean, you're beyond that because of just the really the evolution of what you've done and how you can speak so many different what I call jargons and languages of different types and professions. From EMTs to medics to nurses to all of that, which I hope we get into. So yeah, for anybody really to be double boarded and to really do both of those careers effectively, continuously, efficiently is very hard. And not just ER and any other, ER, ICU, ER sports med, whatever it is. Really, right? Like internal med, they go on to cardiology or fellowships and all. They don't really go back to the internal medicine part of it in that sense. So it's not very common. And I think one of the weirdest ones, and no offense to anybody who does it, because I know some good people who do it, is EMIM. God, I think that's a waste of 2 years. No offense if you want to do it, but I guarantee you're going to do one or the other. And whichever one it is fine. But you're probably going to do one or the other. You're not going to do both. But again, I could say that for the ICU most of the time because everybody who I've met is double boarded or either one or the other. They don't. You're the only one who, again, I've ever met in a 13-year career who does both, again, equally and does them well, does them in the same hospital, sometimes does them somewhere else, all over the place, and obviously an educator with what you do. So I really, really looking forward to our talk. What was the driving force really for you to really want to just take each step up next from medic to nurse, nurse to medicine? What was that? Was there a driving force each time that said, hey, I would just want to do more? Or were you always just, a never settle kind of guy? Or tell me about that.
That I came from, a probably lower middle class, well, probably even lower. I mean, I remember at one point, my family, we were sleeping in my dad's Chevy station wagon at one point when we were kids. So we didn't have a lot growing up, and I'm fortunate for the things that I did have, but it's made me appreciate kind of where I am now, what I can, give, to my family. When I was 15 going on 16, I got hit by a drunk driver. And I spent 2 weeks in a coma and had to learn to walk again. I had both my legs broken. All the ribs on the right side were shattered. Couple pneumothoraxes, broken, my right humerus and forearm were fractured in a couple of places as well. So, when I woke up finally after my coma and spent almost 2 months in the hospital, I realized that that's what I wanted to do. But, like a lot of, people out there, my family, I was the first person in my family to even graduate high school. So I didn't really have a lot of mentorship and direction from my family. So I ended up, that's kind of where the military came in. I finished high school, but didn't really know how to get to what the next step was for me, which was college. So I joined the military and got the money and stuff like that.
Like I mentioned, before even being a physician, you started out as it was an EMT, correct?
Yeah, I was a paramedic. I got my training. I went into the Air Force during Desert Storm, and I wanted to go in as a medic, but I ended up going aircraft structural maintenance, which is like the airframe of the plane repairs and stuff like that. I got out of the Air Force. I continued to work as a paramedic, and then went on to nursing school after that. So I grew up in medicine, starting out as an EMT, running on the ambulance, and then working almost 11.
The interesting in the way, I always talk and about the links in the chain, and we're all links in the chain for saving a life, from the first responder to the medics to the ER to the ICU. You've been every part of that chain, which is amazing to be every structural part of and being involved in saving someone's life. I think you stand uniquely. I know I'm singing your praises every time, but I really mean it. Like it's just so interesting because okay, medic to um, doc, great. We see that often. Nurse to doc, great. Not as often, but often enough. But to go boom, 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 boom. So now the question comes. So you're an ER doctor. You're living like the cool life of being an ER doctor. So where was it that you're like, okay, I'm going to do a fellowship? Like, what was that part where you've already reached, the MD, right? You've got the degree, you've got all that. So what was that extra oomph there for you?
I knew as a medic that that wasn't what was going to be the end for me. I knew I wanted to do more. And that's what pushed me to go to nursing school. Interestingly, kind of where my path to loving ICU, I started off as a ER nurse, and then I decided to try my hand at ICU, and I really, learned to love kind of both environments. I think the emergency medicine provides that constant onslaught of never knowing what's coming through the door, which is exciting. You get to do those procedures and see the things that really nobody in the hospital, no other specialty in the hospital gets to check out or see, because a lot of times you're sending them off to surgery or you're sending them off to medicine, but no one really kind of sees the totality of what we do in any other specialty. But in the ICU, it was interesting as a nurse because you really get to hone down and see, what's really going on with people. In the emergency department, I always tell residents that, really I'm trying to answer three questions. That's it, just three. Do they need to go home? Do I got to admit them, or do they need the ICU? Those are really the three questions I think emergency medicine boils down to. And the ICU, those questions really expand, and you really have the opportunity to kind of tweak and see what's really happening with the patient. And that's where that side of my brain gets peaked and tweaked.
Tell me about before we get into some other things, tell me about how do you balance, or what is a typical month schedule for you? Like, how does that work? Like, how does this work?
So, I typically will do 7 shifts in the ER and then a week straight in the ICU. And I kind of spatter my 7 ER shifts around. But the nice thing about working at the same place that you do ER is, I mean, with critical care, you spend a lot of time in the ED anyway, accepting patients and stuff like that. So it still feels like home. And I get to work with my colleagues and see a different perspective from them. And, when you're in the ER, you're kind of taking care of your patients. You're not really worrying about what the other guy's doing unless they ask for help or, a big, critical patient comes in and you're working side by side. But for the most part, it's disconnected. When I'm working in the ICU, I can come down, I get a chance to really talk with people about, the medical management of the patients and get to share that ICU perspective with them. Because again, I think sometimes when I'm in the ER mode of things, I don't do all the things that I would do upstairs in the ER. Sometimes a little bit of it bleeds through a little bit where I'm, adding on a few extra labs because I know I'd order those in the ER or if I was upstairs in the ICU. I try to share that because some of the things do are meaningful because you're like, like triglycerides with pancreatitis. I mean, I've admitted a few patients from the floor when they go upstairs because the ER doc didn't order triglyceride level.
Don't make me change my management here because you are. I mean, that makes sense, man. Gosh.
No, and then the
Gosh. Yeah, thank gosh that my other hospital is a reflex panel, but gosh, that makes sense. Because this is sorry to interrupt, but this is a perfect segue into what I was going to ask you is how do you balance diff the different ways of approaching a patient, different ways of thinking from the ER doc perspective to the ICU perspective? Because I mean, there's got to be some obviously some overlap. There is obviously we're pretty much extension,
right.
but like you just said, ordering the different set of labs, the things that you're going to follow up that we don't care about, osms and lipid panels and those things, honestly. But knowing that it'd help my colleague is why I would order it. But yeah, tell me about that. How do you switch your brain back and forth from that?
Well, I don't think, I mean, I think it bleeds through a little bit, like I, and I think it's all very patient specific, right? I mean, when we've been doing this for a few years, the patients that are sick and not sick, right? So the people that I look at and I know that they're not staying, then I don't really, the ICU brain doesn't, whisper in my ear, like you should order this. But on those critical patients that I know are kind of on the fence about going to the ICU, or the ones that I absolutely know are going to go to the ICU, then I will add those, like, serum osmols for DKA patients, and I typically will start, and I stopped a long time ago ordering just one dose of IV antibiotics. If I know they're coming in and I'm going to admit them, I reflexively order the antibiotics to carry through. But that's really, I think it's very patient specific and comes with the experience of knowing who's sick and who's coming into the hospital. And then when I know that they're going to be admitted to the ICU, then my ICU brain starts clicking in and starts ordering all the things I would order as an ICU doctor.
Okay, well, so got it there, and that makes sense. Okay, definitely knowing who's sick, who's not sick, and then that person's going home, you shut that brain off. But let's say the approach to this undifferentiated sick patient that you can turn around and intermediate care player versus possibly likely ICU, and you're in that moment right there, and that workup that's required. Where do you go initial? Like how do you work through that? Is there still a little bit of okay? I'm ordering this serum osmols at the same time as all the rest of my order sets, or am I waiting to see, or tell me like how do you work that out?
Well, so one of the great things about electronic medical records is that I started creating some of my own order sets, right? So, my abdominal pain order set, for, like we were talking about, for pancreatitis, an abdominal pain order set automatically includes a triglyceride level. That way, every time it's a simple test, it doesn't take much time to add it on. So I just build out some ICU ER order sets for the patients, that I think are going to end up coming in, or the sick belly painter that has, just looks like they're going to need to come in. I have a order set that's built out for them. But I will say this: I tend to add extra labs on beyond, like, at South Texas Health Systems we have an abdominal pain order set, which I've added several things to that one to kind of make it more of a hybrid of what I need to know as an ER doctor and what I want to know as an ICU doctor.
Okay, right. Now your your schedule is basically about 2 weeks on, 2 weeks off ish.
Pretty much. And then, now with all the residency stuff, that's kind of spattered in there as well.
Oh
So,
yeah, we're gonna get into
yeah.
that. But tell me before we get into that stuff, how do you balance? Because both jobs, both careers are shift work.
Mhm.
And for us shift work people, we don't unfortunately We get very lucky if we have a permanent night guy that gets to cover all the nights and we only work days. So we basically bounce back and forth and we never have a normal circadian rhythm. So, how do you balance that with your family life? And please tell me about your family.
Well, I got a very beautiful, understanding wife, Erica, and my three kids, Anae, which is my 12-year-old, AZ, my 9-year-old, and Jasmine, my 6-year-old. Um, so I My wife hates that I work nights. She absolutely hates it, and I don't like it for the kids. But when I work ICU, I really prefer to work night shifts. So I'm that designated night guy that
Ah,
the ICU team loves because I think when you work ICU day shift, there's a lot there's more administrative stuff going on than there is patient care. You're dealing with case managers nagging you about how length of stay in the ICU and step downs and where they're going to go. You have your multidisciplinary rounding teams, which adds a good extra 2 hours to your rounds. And let's be honest, man, at the end of the day, I'm still an ER doctor. You know, um, 5 hours of endless rounds of on like internal medicine rounds is still super hard for me. ER doctors have ADD, and we don't do well with the attention span of rounding on 20 or 30 patients. So I prefer to work nights where I can do rounds on my schedule if it gets interrupted by an admission or something like that, and it's really more focused on patient care. So as much as that is a bane to my family, I think in some ways, because you don't get to spend as much time with the kids, you're sleeping. My wife always feels uneasy about being in the house at night. Um, but I really do think that it's what allows me to have that separate career. I don't think I'd be happy doing ICU day shifts. And would probably cut it back if I had to do days. And I occasionally I'll pick up a week when they need coverage or whatever. But a week of day shift ICU is more of a reminder of why I like nights ICU so much. So, and then with the ER, the ER, I have been fortunate recently that I've been able to get a lot of day shifts and a few swing shifts, which allows me to kind of have that balance. I'm working a week of ICU nights, and then I do my other 7 days or usually days, day shifts or swing shifts. And honestly, if I could have my dream ER job, I would probably do swings all the time. I like going in when it's busy and staying busy during my 12-hour shift. I hate getting up in the morning, so I'd rather sleep in until 10-ish and then get up and go into work. But yeah, so I think any shift work, the work-life balance is hard, and I think the fact that I've been able to find a sweet spot with working 14 shifts a month. As much as my wife in my family.
time out, time out. That
Okay.
14 12s.
Yeah.
So so 10 12s is full time for an ER doctor.
Uh-huh.
It's considered full time. What is it? What is a normal like full time for an ICU? Is it same for ICU? I'm not sure. Like, tell me.
Dude, I'm gonna tell you. So no, man. I mean, if I was working full time ICU, most of my partners are working 21/12s.
Ah,
Yeah. And on that week that they're not in the ICU, they're usually doing a week of like Palm. Um, and some of the older guys in the group are doing 2 weeks of ICU, which is 14, and then they're doing the other 2 weeks are in their Palm clinic. So yeah, there's really, I mean, honestly, if you work Palm Crit, and I'm not Palm Crit, I'm anesthesia critical care, which is why thankfully they never asked me to go to the office. But yeah, man, if you work a pulmonary crit job, you're pretty much working every day.
Sounds like neurosurgery, where you're just committed, committed, committed. And not that our lifestyle is amazing, but and to be very, very honest, I didn't know. So my brother's an internal medicine doctor. Shout out, Dr. Ramani, in Arkansas, and he works with residents. And he's like, I'm talking to him. He's his second year in as a attending, third year, and he's uh, working. Is it 12 on, 12 off, 10 on, no, I'm sorry, 7 on, 7 on, 7 on, 7 on. So he's working, 7 on, and he's only working days. And he leaves his pager, basically signs out his patients, right? And he's telling me this. I'm like, wait, what? Like, I was never told that. Like, not that I would ever change. And no offense to internal medicine, but ever change. Um, uh, I was just blown away that that lifestyle is pretty. I didn't know that they also have a pretty good lifestyle. They can find it, and he makes way good money. And day shifts only, so he's home with his family. He works 12s, but that's that. So there are other lifestyles that are amenable to a good lifestyle too, and not working palm crit, and those you're committed for a while for sure. But I think ER has that best balance of being able to do that, and the meaning in the sense of you can also choose the pace you work at, right? You can work at a busy level one trauma if you're obviously ABIM certified. You can work at a slow podunk urgent care where you see 12 in 12 hours or 24 hours. So the breadth of lifestyle as well as pace, I think, is the best of both. And this is going to lead into my next question. So as we know, in the last few years, and this is how we're going to segue into the education part. In the last few years, the pendulum has really shifted on the wrong side of applicants applying into emergency medicine. And the major reason this was the COVID-19 pandemic. And us being seen and finally actually recognized as the Bafford badass effing ER doctor, the crazy Fs we are, who jump head into any kind of the canaries in the coal mine, whatever you want to call it. We were finally recognized at that, and I really appreciated that.
That's why you're immune to everything, brother.
The COVID can't touch me. But man, if I work at PD shift, I will get a GI bug times 5. My GI system is as weak as anything. It's like it's got no microbiome. Like I any URI goes right down here, and it just sucks. So although I feel immune to the lungs, otherwise it's probably not the best. Going back to that, like the at it was what 3 years ago, maybe during the residency, the application cycle, the match cycle, there was one unmatched position, right? And then we got down to that, and then boom, the next year it was 200 and something, the 200 and change, and then the next year it's 500 and change. So this year this past year, I'm sorry, we were very worried because we didn't know which way this pendulum is really going. In the sense of, are we at the trough? Is it the trough? Is the trough the bottom? Yeah, the trough, right? The peak's the top. Yeah. So are we there, or are we still swinging really in the negative direction? And this year, I'm going to ask your opinion, but I feel the numbers got much better, but I think they were falsely bolstered due to the influx of non-American graduates applying into emergency medicine. So because the hit we took in applicants, the application process got easier. And then so although the numbers are higher, it's probably not as high as we like to be. We shouldn't sit that or rest that well, like well comfortably right now about our profession and our profession's future in that sense. And this season, the match season is currently happening right now. It's in process. Best of luck to everybody in the match, by the way. Um, and we will see again what the numbers look like. And even in, I hopefully I wasn't too negative, because again, any positive is better than anything negative. And I don't want our profession to stumble in that way and give way. And the reason I say that is because that weakens us and gives hospitals and CEOs and admins an option to test other options of putting pure, which they've done already in different states, different models of emergency medicine where they put pure mid-levels or advanced practice providers in and have a physician and ER doctor via telehealth or Zoom available. And this is going to, we love our mid-levels and we love working alongside them, but they're just, the training is different, and nor can they run an emergency room. And so that is scary. And so these are the things that scare me. So that's why we need a constant influx, or a constant, pool of great candidates to come into emergency medicine. And when everybody who's probably listening to this has listened to many of my things. So, and when I say great candidate, I mean well-rounded, I mean street smart, I mean obviously educated, but we're not talking about publishing 10,000 papers on microbiomes and eukaryote cells. I don't even remember what a eukaryote, or is it a bikaryote or a trikaryote? I don't know, because it doesn't matter in medicine. Be honest, right?
Jamal, I agree with
So,
you, man. And
so where do you see the landscape of emergency medicine in the next 10 years?
well, I went to Cord the last couple of years and got to listen to, they had like whole panels on, what was the cause of it. And you're right. I mean, COVID, them taking medical students out of the emergency department for a couple of years, not letting them really experience the fun of emergency medicine, and really what it meant to be an ER doctor, I think really kind of hurt us in recruiting. And being pictured as the front line of medicine during COVID, where people weren't getting, or people were getting exposed and dying, but not really getting a chance to see the protection that we were putting in place to make sure. I know I got at UT, I got issued basically a respirator with a HEPA filter and stuff like that. So, I mean, although I think in many respects we were cowboys in medicine, we did really respect the disease and what it could happen, but medical students didn't get a chance to see that, So I think you're right in the fact that IMGs this last year really were the uptake in where we filled from. I looked at the match data, and we really emerged, like US grads kind of went up a little bit, but the number of IMGs really took a huge increase this last year. And I think that's why we dropped from 554 down to 135 open spots. And thankfully, during the SOAP and secondary match processes, all the EM spots end up filling. And I don't have necessarily anything against U.S. graduates, or I'm sorry, IMGs that go into emergency medicine. Learning through this process of reviewing applications and stuff like that, I do think that there are some things that are unfair. Like, some of the students that I'm working with now, they're taking off 2 or 3 months to study for for boards. U.S. students don't get that opportunity. We have to take our boards concurrently with our other educational requirements, and being able to take 2 or 3 months off or 6 months off to study, I think is an unfair advantage to students, and certainly one of the things that has to be looked at when you're evaluating IMGs. But I think over the next couple of years, U.S. graduates are going to get a chance to really see what emergency medicine is, and will start coming back to the specialty.
That being said, so we've brushed on it a couple times. You are not only an emergency medicine physician, not only a critical care physician and attending, you're also the associate program director for the, as you mentioned, South Texas Health Systems Emergency Medicine Program, residency program.
Well, and let's be fair, you are the program director for the South Texas Health System emergency medicine program. So we're fortunate to be able to work together, not just in the ER, but in building this program. So, I really do appreciate your friendship, the mentorship, and your passion to build this together.
Yeah, so I will tell everybody that it's really the other way around, the mentorship and everything else. So, yeah, Mike is my brother. I consider him my brother. We've been through a lot building a program. We can talk about that real fast. So we, 2023, I guess, right? Got together with some ragtag group of people and decided to, hey, a program needs to be in place for a city, if I can say that, since I've been going down there for just about a year, over a year and a half now, I have fallen in love with McAllen, Texas. I'm in Houston, so it's a 5.5 hour drive or hour flight. And coming down there and helping, and then really, meeting everybody and starting, helping start this program, I realized while working in the emergency room down there what the importance of keeping physicians down there, and meaning training physicians, because everybody, I'm a traveler at this time and at that time, and a lot of people around me were too. And so, although committed to, the emergency department, and we're, working, like, I don't think you have that commitment to the community in that sense of, like, hey, I see these people every day on the outside, right? I think that's an extra love when, if you get to, and lucky if you get to work in your own community. Not everybody does. But I fell in love with that and the people, and realized, oh my gosh, like, this is the reason there is not an emergency medicine program that can serve the people, and in doing so, keeping physicians, and not everybody's going to stay. We know how residency. I trained in New York, right, and I'm in Texas. I'm in Houston now, so no, not everybody. Majority of people do not stay at the program they trained at, but over the years, to put emergency medicine physicians in the community and grow that community and have that trust be built is such an important thing. And it's so lacking in such a wonderful community, and to be part of a health system that realized and had this epiphany of saying, we need this, not we, the community, we need this. And to go find such a wonderful person like me, I'm just, but to put this whole package together and back it up, not only with words, not only with money, with commitment from every CEO, from every hospital, commitment from all the education people who we can list off from here to there, and to see that, because again, I've been lucky enough to help build the program here in Houston, where I've been core faculty for 6 years. So it was just such a wonderful thing to really do that over again, and be a part of it, where I know that over the years and more years and years, there's going to be just people who stay and really commit to this community of, I think it's 1.8 million people. And so tell me, how has the process been for you? and then we'll discuss about the match process and where we are currently. And tell me a little bit about the hospital itself, and the McAllen, if you don't mind, because you know it much better than I do.
Well, I'll start off with McAllen and stuff. So, I mean, like I said, earlier on, I came here as a nurse, and I came as a travel nurse. So my intention was never to come here and stay here. But, I was fortunate. I met my wife while I was here, and she kind of drew me back to this. Went to back to med school in DC, where I'm from originally, and then did fellowship at the University of Alabama. Did ER training in Corpus Christi to kind of be close to her and foster that relationship. But once I got to UAB, I never thought I would come back. That was kind of like my place I wanted to retire from. But my wife got pregnant with the third kid, and she was like, "We're going back." Um, so the community definitely grows on you, and there's been McAllen area is in the news a lot for, I mean, there was a piece done in the New Yorker a few years ago about, medical misuse down here and insurance fraud and stuff like that. And then recently, I think McAllen was voted the fattest city in the country for morbid obesity and highest number of diabetes. And then I think the thing that most people don't realize, and I certainly didn't realize, even having worked here as a nurse, is the whole idea that this area and probably most other border cities, you're not just serving the community, the citizens of this community. I don't know how many times on shift I get a patient that is coming here from Mexico. And for many of your listeners that don't realize, or deal with border medicine, even, and this has nothing to do with the current political, because it happened even when I was a nurse. Most of the Border Patrol agents and checkpoints will allow ambulances to come across the border, or for humanitarian reasons, will call a U.S. EMS. I've had a lady who had a fresh craniotomy for a bleed, who was literally dropped off on the checkpoint bridge, and they called an ambulance and brought her in. So we get a lot of, we are the safety net, not just for U.S. citizens, but we're also the safety net for Mexican citizens that, in our sister city, Reynosa. So, there's a lot of, border crime that happens over there. We get, U.S. citizens over there, having a good time, dinner or whatever, they get shot, they'll come across. But we also get, patients from that are, truly, live and work in Mexico, and they, come across because Mexico is a fee for service country. So if you can't pay, the hospital doesn't let you stay. So, so that's been a unique thing to, and something that I think I truly cherish is the fact that I get to serve two countries, and provide healthcare for them. And then, of course, the area, man. It's McAllen and Edinburgh are hot cities to live in. It's super hot down here, but you get used to that, when they come and go. But it's an incredibly affordable city. I know when I was in Birmingham, and I'm sure in Houston, looking at a 3,000 square foot house on a half acre lot, you're looking at an easy $500,000 or more. I was able to get a ranch style place. I got 20 acres and a nice house, and I paid that same $500,000. So as far as being able to live in a city where you get to change the healthcare and life of two countries, for the most part, everyone, because you're working with a large immigrant population or first generation Americans, they're super thankful for the care that they receive. And I school system is very good here. So I think there's a lot of pluses to being in the area as a healthcare provider. The biggest one being that how important the work you do is every day, because they are flying a lot of physicians in to work here, and to know that I'm not coming in and I'm part of the community. I work with the EMS people. I do education for a lot of the EMS agencies. So, I think I'm touching more than just coming in, because this really is my community.
You're into hip hop or not, but like, every time you go to some city, you got to touch down with the ambassador of that city, and make sure everything's okay. You're like that. It's your home, and it feels like my home. And being a city boy, as far as being in Houston, the third largest city in the country, overtook Chicago. So, um, the things I can tell you is I love the community I work for and the patient population mostly. But I've worked down in McAllen for a year now, and I have never been called a racial slur. I hate to, like that's it's Houston's Houston. I love Houston, but and you're 100% right. From again from my the outsider coming in perspective. Um, not myself being growing up poor and not going to doctors and waiting 8 hours for an X-ray in the ER and then being discharged without it, talking to the doctor at all, and those things are very common. So to see the appreciation, just makes you want to do so much more because coming from my background, I realize that's how we were as well, and just to have people who care and will do that and sit with you and take the time to talk is so important, and you're definitely one of those. The other thing about it is, yeah, you're right. I will tell you, super interesting to come from again a major city where it's you have insurance, you don't have insurance, okay, that's fine, you're American, you show up on our door, you're going to get treated. This is EMTALA. We can that's up for a whole different discussion, but it is wild when I first started working down there to be like, there's these guys, standing at the doors. I'm like, what the F is going on? They're like, oh, and people had to explain to me, like, they're people who are close to the border. We're in McAllen again, our, a level 1 trauma center, McAllen Medical Center. What is it, like 9 miles away from the border, so something like that.
Yep.
So I had no idea. It's just, like, boom. And these people were sick, and we get to treat them. And I think that's freaking awesome. Because first of all, educational wise, it expands every differential, throws your differential to the spaghetti on the wall, right? And what I mean by that, if I can share one funny story, I know this is getting long, but one funny story. This was just my last about 3 weeks ago when I was in McAllen. So I had this young lady come in. She was all sick as shit. Like, oh God, blood pressure 70/50. She was 30-year-old lady, on death's door, like. After 3 liters of fluid, she is 85/50. Like she's not doing much better. Pressure support happens and all this other stuff. And blood work comes back, and gosh darn it, the smear to CBC, the differential, she's got malaria. The second time I've actually seen it. First time was in Houston, and that guy died, and he was young. And it was just humbling to see true malaria, right? And I'm like, oh, so I triggered this immediately. I was like, oh, shoot. This is how sick that other guy was. It's like, oh my gosh. So I call the infectious disease doc, and I'm like, hey, I got this young lady who's like pretty sick, and she's got malaria. He goes, why the hell did you think she's got malaria? I was like, I never thought she had malaria. The lab report told me she has malaria. I was like, that's like number 70 on my differential. I mean, like and he starts laughing. We have a great conversation, and all of that. And she ends up, she does well. So she survives it. But I go back and ask, and he tells me to ask. Because, again, I say, I am new down here. I don't know, like I know what I know. And I know there are things I don't know. And I think that's smart as an ER doctor to be like, this is a different tropical medicine. There are disease processes I've either read in med school and have forgotten, or I've never absolutely heard of, right? Like a mycetoma. I've seen it twice. Look it up, my MYCOT. TOMA, whatever, if you want to look into it more. But I've seen it twice in McAllen. Never have I ever heard of it or come across it or anything like that in anywhere else. So the differentials be damned. It just broadens them. A 2-year-old with familial relapsing Mediterranean fever. And like I knew I remembered that in med school, but other than that, never saw it on a board question or anything. And so to see being this late in my career, 10 years, over 10 years out now, and being like, okay, yeah, like I love to sit down and think and get nerdy with some things. I can save your, I tell everybody, I can save your eyes with my eyes closed in my sleep. That's the easy part. It's this, other aspect of medicine now going back to oh my gosh, I am dealing with a different country, like you said, a different population. Although I'm still lucky enough to live in America, I am literally dealing with two different populations of people. And sometimes there's kind of like disseminated TB, those like they're just so, and unfortunately,
Jamal, I don't want to interrupt you, man, but the last 4 years, I mean, it's actually not just been Mexico. We've been dealing with, worldwide populations. I mean,
so my malaria lady, I asked her, where did you come? Because the ID doctor, he asked me to ask her where she came from and how long ago. So I just crossed the border last night. So, and this like 3 o'clock, 7 o'clock in the morning or 8 or something like that. I'm like, oh, from where? So I came from Honduras.
yep.
Right. Right. So, and again, I know that beyond just even Central America and all that, but yeah, she was not from Mexico. Mexico was a final stop before crossing over to here. And it's just wild that she along the way caught malaria and just made it within hours before she would have died.
Yep. Yeah, man, and I think collectively, if we asked all the ER docs and that we work with, there'd probably be 1,000 stories like that. It's an interesting place to practice, and I think a very interesting place to have a residency program because our residents really are going to be exposed to the world. I mean, you can't get that from many other training programs in the country where you're going to get to not just serve your local community, but to serve the worldwide community.
Absolutely. And so with that sounds like in the near future where fellowships of international medicine border things like that are to be hopefully not expected but thought through thoroughly and so yeah, that's exciting. I 100% am with that. It's the eclectic nature of emergency medicine again, heart attacks are heart attacks. And I know there's 5 types of MIs nowadays. Yeah, yeah. But that rash could be fungal, bacterial, viral, allergic, contact. Gosh, and I don't want to get too nerdy and give my medicine colleagues too much credit. But having to nowadays think through some of these things is fun, and it's fun when it's when it's interesting, I guess, when it's this undifferentiated and you're dealing with something so brand new. It really reinvigorates my career in the sense of I'm dealing with disease process again I've never seen. I have to work up, and then I get to go home and read about them like a resident would. I hope they do. I hope my residents do. Like that they would, and just learn about these things because again, you're going to see them again, and so you're going to be able to help that second patient even more than that first patient by what you learned. And because we always learn off the backs of our patients, and as long as we learn something for the next person, I think that's what makes it okay. So where do you we're in the match right now, right? Like everybody's in the match right now. So the match is happening. It's more towards the tail end of it, and where we're in January. So somewhere in March is where people get those letters and those emails and start scrambling and those things. Tell me about what kind of class generally do you see in your program? Like, what do you, in our program, what do you see or ideally, I guess, would be a great incoming first class or yeah. What do you think?
Well, I mean, you and I have been, working to do this kind of neck and neck. So, I mean, for our first class, I'm hopeful for um, a group of people that are going to help us build the program. I mean, I think, we've done a lot of work on the back end and try to anticipate everything. And, there's always meetings about one thing or the other. But I think, I really hope we get people that are willing to take up that challenge with us and help us build something that's, enduring beyond, our career in medicine. Um, with some flexibility, man, because like I said, we've tried to figure out and think about everything that we can, but I know that there's going to be stumbling blocks along the way, and we need people that are going to help us to overcome those stumbling blocks and not complain about them.
Yeah, and one of the things that I don't think people, having and you too, having worked with residents for so long, it's an interesting and very unique because it only happens once per program in its lifetime. Is that inaugural class,
Hmm.
right? And I've been a part of one, because we built one here in Houston, and now that inaugural class is special because if you guys think about it, all who are listening out there, there is no resident, senior resident, no buffer between yourself and the attending. So what that means is, when you come to a residency program, you're the intern, right? Well, you have a second year, third year, maybe a fourth year. So you have nobody. It's just you and some people might be scared of that one-on-one. You learn so much more. And maybe fortunately, unfortunately, I mean, you learn the good things as well as the bad habits of the attending. I've been through this with our inaugural class. And it's such an intimate experience because once again, there's nobody to do the procedure other than you. So you get all the procedures. You get that attending way of thinking at the same time of because it's direct one-on-one feedback all the time, right? You code together, you do the procedures together, you're seeing that he or she's overseeing your patient. So that next class that comes in now has a buffer of you, the intern does, of you between the attending. So there's never again in that program going to be that kind of intimate connection. So, Mike, what do you have to say to going back to that mentorship we talked about to a paramedic, an EMT, a nurse who just thinks they can't? Because I'm sitting in front of somebody who did, and I would not think it's possible. I mean, just to go and evolve up and up and up and up. And what would you say to that person listening, viewing right now, who is in that situation of like, do I bite that bullet? Do I not? You know, what should I do? And I just don't think I can do it.
So I will, to me, and I'll be open and honest about my story. So, my decision to go back to medical school, cost me a marriage. You have to. Sometimes it's a sacrifice, but you have to really look at where do you want to be in life, and sometimes what is it going to cost you to fulfill your life dream, right? Um, and and that's I had great mentorship. I had people that were pushing me along, but at the end of the day, you have to make sure that it's the right decision for you. I think, I told you about Dr. Reyes who mentored me, but there was another guy that I worked with when I was a nurse, and um, and he told me that a trained monkey could do a nurse's job. And I thought to myself, that was kind of, I won't say the final straw, but that was one of those things that just adds that kindling to the fire. Because I thought to myself, well, you know what, asshole, I'm going to go back, I'm going to do your job. So a trained monkey is going to do your job too.
Oh,
Um,
God, those haters.
yeah. So I don't think, and I don't think doctors are necessarily smarter than anybody else. I think there's just a level of dedication, I think, that separates us as people. And I think if you can look into yourself and you know that the only thing that's going to make you happy as a career is to be a doctor, and you have that grit and you are willing to sacrifice, to be where you are. And it is a sacrifice. You're sacrificing time away from your family. You're sacrificing, sometimes in some cases your youth. You're giving up 4 years of college, 4 years of med school, plus the training programs and stuff like that. And it's hard to find that work-life balance. I mean, you can, but I think at the end of the day, it's doable. You have to make that decision to do it and not look back, um, and be willing to sacrifice time, because that's ultimately what you're sacrificing is your time. Um, and if you're willing to make that commitment and know what you're getting into, um, then anybody can be a doctor. And I've come across, there's a couple of medics that worked down at South Texas in the South Texas area that have come to me and asked me questions about what's the next step, and how do I do this, and I fully encourage anybody that wants to be a doctor to pursue that path. So it just know that it's achievable. It just takes that dedication and willing to sacrifice.
I agree. More commitment than, yeah, like you said, everybody's got a brain. We're all born with the brain, and the commitment is the commitment. And even, well, let me ask you this. This is my hard question for you. What will you push your kids or nudge your kids or want your kids to go into medicine or become physicians themselves or
So that's a
require
challenge.
it?
You are right, right? So that's the hard question. I want to be that dad that says that they can do whatever they want to do, whatever's going to make them happy, right? And and we have our kids doing. I mean, my daughter plays the saxophone, she's a cheerleader. My son does Brazilian jiu-jitsu, and is going to play baseball this spring. Part of me, honestly, my selfish reason for working so hard for the residency program is because I would like to see just one of my kids be my resident, before I retire. I would love to be able to watch one of my kids grow through medicine and be able to be a part of their training. And then I think as a parent, this world is getting so hard, dude, and the everything is getting so expensive. And coming from the life that I grew up in, and I tell my kids all the time, whatever you want to be a doctor, you want to be a lawyer, you want to be an oil rig worker. If you want to have this kind of life, you have to make your choices of what you want to do. And I try to tell them now, I don't think they understand it, 6, 9, and 12, but what you can provide for your family is directly related to how much work and what kind of work you do in life. And, so do I want all of them to be doctors? Yes. Would I be happy with a lawyer? Sure. But I think, my wife's a nurse, I'm a doctor. I do want them to be happy in life, and I would really like for them to be successful. And if that is, being a doctor, I'll be super happy. So I do nudge them a little bit in that direction, but I just want them to be successful and happy.
I agree with this. I'll one up you in the sense of um, nudge for sure. Obviously you can't force anybody to do anything, and it's their life and whatever they want to do, and as long as we love them. But I think the COVID pandemic really showed us a lot of medicine in the sense of if some bad faces of medicine, unfortunately, but also if you were more likely to be seen in a hospital, be treated if you knew somebody in the hospital. I mean, that's just the way it went. And people who
Mhm.
were in the medical field had more access or resources in this. And this is not data backed. I don't have a study to show you right now, but it's an anecdotal and obvious common
Mhm.
sense. You know, something that happened all the time. You know, like so you might be seen better. You can at least get medications called in, right? Because no doctor's office is open. So to be somewhere, physician or not, I don't care. But my thought, this is mine, is medicine is going to be one of those fields where as global warming happens, as people move closer, as you know, more things get burned down and more, you know, jungles get burned down and more viruses are released and more pandemics become more frequent, medicine is the name of the game. That's just, you know, my conspiracy there's prepper mind thinking, I guess. So, you know, I don't necessarily mean physician, but I mean medical field and medicine in general is where I would like to nudge them. And again, I don't, if it's a doctor or not, you know, I don't care as long. But yeah, I agree that it would be nice. And that would be awfully cool to have one of the veterans. That warms my heart, man. That is cool. And I think I lied to you about that being the hardest question because I have one last question before we go.
All
And
right.
you know, because you know my motto is "We are ER." So if you had to pick, if there's a gun to your head and you have to be this one for the ride, you got to leave one. Which one are you leaving, ER or ICU? Are you
I
gonna
would
tell me?
leave it to you, man. At the heart, at the core of me, from being a paramedic to an ER nurse to an ER doctor. I mean, I like the outside of the box thinking of ICU, but man, you know, there's nothing like being on that shift and that constant onslaught of patients coming through the door that you're being challenged with every moment, the procedures, being able to, drop a line, intubate, crack a chest. I mean, I think for a non-surgical specialty, by far we have our hands in everybody's pot. And I would not give up emergency medicine for anything.
That is, and you answered it pretty fast.
Yeah, dude.
And that's obviously an awesome answer.
Yeah.
Um, That's great. Yeah, that is wonderful. Well, I think I've taken too much of your time. And I want to thank you again, Dr. Mike Menowsky, for joining us today and being able to give some of his expertise. And again, uh, I thought this didn't exist, you know, and boom, you know, meaning, you know, to be double boarded and doing both at the same
Soon to
time,
be triple.
triple
I'm,
soon to be. Tell
yeah,
me.
I'm gonna go and do my neurocritical care.
Oh, gosh. Overachievers down in the valley. You know, not the California Valley, but the Texas Valley. All right, the overachievers. And wow, wow, that is amazing, amazing. I'm going to definitely need your help as my brain gets more and more shriveled and shriveled. So, look forward to our next conversation. And thank you again. And any last words from your end?
Well, man, like I said, from the bottom of my heart, thank you for joining me on this journey and ultimately, making this journey possible. Because without you as our program director, our program would not be started. So, the friendship, the mentorship, I truly mean that. And I think we can grow and learn from each other. And I look forward to spending the next several years with you, molding these ER minds and watching our first class graduate, and going on to see what the future brings. I'd like to see some fellowships um, and change emergency medicine in the region.
So, thank you again, Dr. Manowski.
All right, brother. Well, thank you, man. And